Welcome to The Conversation. I'm your guest host again. I'm Harlan Shaw, community member, community activist, and today's topic, we're going to be talking about vaccines and to bring up attention to the National Vaccine Awareness Day, right? Today, we have two guests with us, Dr. Ian Frank and Dr. Devi Watts. They are going to be talking about some of their work. So I'm going to give a chance to Ian. Could you introduce yourself?
Sure.
Thanks,
Harlan.
Thank you.
So I'm Ian Frank, a member of the Infectious Disease Division at the University of Pennsylvania. One of the guys who leads our HIV clinical trials group, and I'm responsible for the prevention work that we do.
All right. Dr. Watts, would you introduce yourself?
Sure. So I'm Dr. Devi Watson, look like a bird. I am also an infectious disease physician here at the University of Pennsylvania, and I run integrated HIV prevention and treatment clinic where I prescribe gender-affirming hormone therapy and coordinate care between Penn and other clinics here, as well as Philadelphia FIGHT, which is a federally qualified health center here.
Awesome. So next week is coming up. It's National Vaccine Awareness Day, which is why we're here today. What projects are you guys working on? What research are you guys working on in your office? Who wants to go first?
I'll let Dr. Frank go.
Dr. Frank.
So there's really a lot going on in the world of HIV vaccines right now. We've been in the HIV vaccine business for a number of years, and we've done 8 big trials, and we only have one that has shown any benefit, only about a 30% rate of protection. So our track record is not very successful.
Yes.
But we've got a whole new wave of approaches that are designed to stimulate the immune system in a different way than the way we've done it before.
Okay.
So we've got an assortment of early phase, what we call phase 1 studies, that are exploring these new different approaches to see whether or not we could stimulate the immune system to make what we call a neutralizing antibody, an antibody that can inactivate HIV just by itself. So most of the work we're doing right now is testing these new strategies. But we have one large ongoing HIV prevention vaccine study where we're testing a vaccine combination in men who have sex with men. And this study has been going on for a couple of years now, and probably over the next year or two, we'll see if this vaccine combination can prevent people from getting HIV infected.
Okay. Now, you talked about some new techniques. Were these new techniques developed due to the coronavirus and coming out with their vaccines, or did that contribute anyway to the work you're doing?
Well, some of the new vaccines we're testing are using the mRNA vaccine platform, which has gotten a lot of attention, the first ones with COVID. And the advantage of that strategy is you can develop a vaccine really quickly with mRNA technology. You know, with COVID, they were testing a vaccine about 3 months after the SARS-CoV-2 virus was initially identified. So really amazing speed. And that's going to enable us to test a whole lot of new different kinds of approaches, hopefully quickly, and get an idea of whether or not we'll have something that could move the immune system in the right way. Because there's really a race going on right now in the HIV prevention world between vaccines and PrEP. And we've got a lot of successes with PrEP, not so many with vaccines. But we think vaccines are important because they're inexpensive. You don't need for people to take them reliably. You could just make sure that they get them, measure an immune response, and if they make the right response, hopefully they'd be protected. And right now, PrEP is really medicalized. People need to come in, be monitored frequently, get a couple of injections every 2 months, or be seen every 3 months if they're taking an oral pill. So it's not the ideal way we like to prevent any medical problem. So we need vaccines, but the strategies haven't been effective. We've got a lot of effective PrEP strategies, not a lot, but we've got a couple. But they're a little bit more complicated to implement.
Okay. We'll get back to that. I want to give Dr. Watts a chance to talk about some of your work.
Sure. So speaking of prevention, Dr. Frank is the vaccine expert and the PrEP expert, but certainly the vaccine expert. I'm more on the biomedical HIV prevention from like a PrEP standpoint. So right now I'm the site investigator of record for a study called HPTN 091, which is a study that's taking place multiple cities in the US as well as Brazil. And it's a unique study in that all of the participants are trans women or women of trans experience, which is sort of like the first of its kind. It's even called a vanguard study because we sort of recognize that this is not how even very well-funded HIV prevention research has been done. It's always been sort of a very small number, and then other than that, mostly cisgender men who have sex with men. So my current work as the investigator of record for the Penn prevention site is sort of coordinating with a really wonderful team that Ian's assembled, a trial that is providing both PrEP, Descovy, and Truvada, but also really importantly focusing on like what are other skills and resources that women need to really thrive in their lives, because so much of the care that we provide for LGBTQ plus folks is disease focused, right? And so the really wonderful thing about this study is that it sort of recognizes that sexual health, HIV prevention is just one component of what these women need. And so that's sort of my role in the Penn clinical research site right now.
Thank you.
But Dovey tends to
Downplay
sell
it.
herself
Yeah,
short.
of course, yeah.
But part of prevention is about behavioral change, and not necessarily changing sexual behaviors, but recognizing the need for an intervention, being willing to accept it, take it regularly, and Dovey's expertise also is in the behavioral space and the implementation space. We've got some good strategies, like I said. How do we make them readily available? How do we convince people to use them? What do we need to do to get them to accept it? And that's also a major part of her expertise. So talk about that.
Tell us about those strategies that you have.
Well, thank you. So I think that one of the things that sort of makes my approach to research, HIV prevention research, is a little bit different. I have a few things. So I'm a Black queer cis woman, and so for me, my commitment to this work is a little different, I think, than a lot of other folks with whom I work who do exceptional work, but it's my community.
Right.
And so I think that my buy-in is just a little different. And a big component of the research that I do is really focusing on not just like the individual patient, but really like what are the providers doing? What are the healthcare systems doing? What are the public health departments doing? Because we know that certainly, right, we want folks to, if it aligns with what they need, we want folks to have access to PrEP. But they have to know about it first,
Right.
and they have to find a provider who's going to ask questions about them in a way that's respectful. They have to be able to like get to the clinic to get the medication. They have to be able to afford it. They have to, and so as Dr. Frank said, it's just very medicalized, and a huge part of that is addressing sort of the the stigmatizing way we approach sexual health, particularly for queer folks, and making sure that the programs we develop for PrEP are really responsive to that and acknowledge that. So my work and my soapbox is really sort of prioritizing providers to get their act together, which makes it a little different.
So I have some background in PrEP as well. That's where my day job is, working at Philadelphia Fight.
Yes.
One of the biggest issues I see is getting cisgender women on PrEP. Like, what strategy would you have for like reaching out to that community to get them, convince them about PrEP or talk to them about PrEP?
Yeah.
Yeah.
Well, I think that the biggest thing is actually like acknowledging that cis women, particularly cis Black women, are vulnerable to HIV acquisition, and a lot of that risk actually isn't related to speaking to their sort of behavioral. It's not, what they're necessarily doing. It's like, what are their partners doing? And so that's one of the reasons why PrEP is so wonderful, because it gives cis women the power to sort of independently, take something that helps to protect them. But providers just don't think about cis women when they think PrEP, right? They think cis, usually gay, like bisexual men, they're not even thinking about that either. Trans men, they're not thinking about that either. Trans women are not thinking about that either. And honestly, overwhelmingly, white cis men. So a lot of it is making sure that the way that we study it, we're including them, the way that when we create programs, we ask cis women, what are they interested in, right? Do we want to integrate PrEP into contraceptive, reproductive health, right? Do we want to reach out to women in their pregnancy visits, right? Is it in primary care? How are we accessing women and what do they need?
Do you think, so the ring,
Yes.
has been released in South Africa, right? Do you think it's something that we should have here in America too?
I'm of the opinion, as much variety as possible. I think think that's great. Similar to contraceptives, it's like you have pills, you have rings, you have implants, you have shots, right? And you sort of get to pick what can integrate into your life, what works for you.
Yeah, and it's more it's familiar for a lot of women to have a ring. Is. So I get it.
Yep.
What are your opinions on that, Ian? About the
No, I agree with Dovey. I think it's about options. It's about choices, and people have different lifestyles. People have different relationships with their partners. Some prevention modalities, may not jive with the partner. Some cisgender women who use a ring say their partners can feel it. And that may not be an obstacle, but some women who may have, be in complicated relationships with their partner may not want their partner to know that they're using an HIV prevention modality. So that ring may not work in that case. A pill may work, or a shot may work. On the other hand, a ring, doesn't lead to systemic side effects because it's a locally applied prevention methodology. So you don't have to worry about a side effect if you use a ring. So there are advantages and disadvantages to a lot of different approaches, and the choices give people options for their initial preference, and if that doesn't work out, there's still something else you can go to.
I did not know that about the ring, that you didn't have side effects because of that. Learn something new every day. Thank you. But there are other options out there. So there's not just Descovy, there's not just Truvada, and now we have just added recently this year Apretude, right?
Yes.
To the mix. But there are other modes of prevention or PrEP coming down the road. Do you guys want to talk about that?
So there are other long-acting antiviral strategies that are being developed not only for prevention but for treatment.
Yeah.
And a couple of them are stalled right now. There's a drug called islatravir that folks are trying to develop that product as a maybe 1 pill a month HIV prevention or treatment drug. There's a drug called lenacapavir, and that development program is also on hold, but that may be one injection every 6 months. There are implantable devices. Dovey was talking about implantable contraceptives.
Yeah.
This is potentially an implantable HIV PrEP, where you've got a little straw with the drug, it gets inserted in the arm, stays there for 6 months, and then either dissolves or you take that one out, you put in a new one. It's things that would totally change the HIV prevention landscape.
Right.
They're coming down the road. They'll be a few years away, but there's a lot of promising things. And it's great to see companies still investing in these strategies. When you're being skeptical about big pharmaceutical companies, just remember that some of them are developing decent products that save people's lives. So we shouldn't all be bashing the drug companies. Not all the time. Some of the time maybe, but not all the time. And then there are other strategies. Monoclonal antibodies. So,
so could you explain that for?
Yes. I mentioned a neutralizing antibody concept. So, there's two parts of the immune system. There's the antibody part, and there's what we call the cellular immune part, the lymphocytes and other cells that are destroying the infected cells or the virus by itself.
Right.
So, in order to have a HIV preventative vaccine, we think we need to get the immune system to make a neutralizing antibody. And that may be a challenge because of the shape of HIV and how the antibodies would need to bind to the surface of the virus in order to neutralize it. HIV actually protects itself in a certain kind of complicated way. Scientists have been able to take cells from people with HIV infection and clone the cells that make neutralizing antibodies and then purify them. And we participated in a very important study called the AMP trial that showed that if you administer these neutralizing antibodies, and we gave them through an intravenous infusion in the arm every 2 months, you could prevent people from becoming HIV infected against virus that was sensitive to the antibody. There's a lot of virus in the circulation in the community that wasn't sensitive to the antibody, so some people got infected. But we are going to be testing combinations of antibodies, just the way we don't treat people with HIV with one drug, sometimes one pill, but that one pill may have 2 or 3 drugs in it. It's going to be the same kind of strategy where we may need 2 or probably 3 neutralizing antibodies that we can give people in combination. We may need to infuse them, but they're trying to modify the antibodies in a way that they could be concentrated and have a long duration of benefit once administered to people. So maybe you could give them by a shot every 2 months or 3 months or 6 months. So that's a different kind of preventative strategy. It's more PrEP than it is vaccine, but it's another strategy that's in development.
And when do you have an idea when that's going to, you guys going to start that phase?
Well, we're studying, these neutralizing antibodies now. There's one study that we're going to be starting probably in the middle of 2024
Okay.
with a 3-drug combination that's particularly promising, that if that looks good, that will probably be the next major HIV prevention study that's done really anywhere.
Okay. Wow, that's amazing. So just so, like for the audience, how long does a study normally take, like from beginning to end, to get to your end goal? So the study we were just talking about, how long would that take?
So these big prevention studies that include thousands of people,
Yeah.
it takes a year and a half to enroll everybody, and then you're following people for, maybe on average 2 years or maybe a little bit longer. So that's a process that takes 4 years. The early phase 1 studies that may have 40 people or 50 people, we can do that study in a year.
Right.
So depends upon how big the study is, what
many
the
people
objective
participate,
is. The prevention studies are more complicated because people who are in vaccine studies, they're eligible to take PrEP if they want it because PrEP is available, so we can't stop them. And if people are taking PrEP the way they should, these interventions protect pretty much everybody 100% of the time. So the only people where we can actually see the vaccine working potentially or the neutralizing antibody working is in folks who aren't taking PrEP the right way,
Okay.
not adhering
Yeah.
to the strategy. So it makes the studies harder to do. We need to enroll more people, follow folks for a longer period of time.
And you have to trust them, but they're reporting back to you that they're taking their medication or not taking their medication, depending on what your needs are, right?
Yeah.
Yeah.
But look, this is the real world, and some people are really good pill takers, or they're going to come in every 2 months for their shots, and some people aren't going to do that. And there's a lot of complicated reasons for that. For young folks, there's stigma, anonymity issues. Folks may be on their parents' insurance, not wanting to have their parents know they're taking a PrEP.
Right.
So there's a lot of reasons why people may not adhere to PrEP or accept it and use it the way it's ideally used. And again, it gets back to the choice issue. That's why we need more options.
More options. All right. So thank you, because I agree with everything you just said. Every day I'm fussing with our patients about their adherence, and there are tests now that we can, for Truvada and Descovy, that we can take to monitor to see if someone's adherent to their medication. But yeah, it's the biggest struggle at my job. So I hear your pain. I feel your pain with that. What is the role that the community at large could take in supporting you guys in your work? Like what could they do? Just the average Joe.
The average Joe who is not actually enrolled in this study.
Not enrolled in your study.
So, I don't know what your friendship group is like, but I have a very wide spectrum of friends. And I have some friends who are boring, like me. And I have some who are very much enjoying themselves. And we talk about how they're enjoying themselves. And I have frequently, I can count, I don't even think I can count on one hand the number of friends that I've had where I'm like, you should probably talk to your doctor about PrEP. This is what it is. These are the options. These are things that you might want to think about. And a few of them, not all, a few of them have started PrEP. They may not stay on it. Some have, continued it for years. But, if you have friends, now, everyone knows about PrEP, right? Like the people watching this know about PrEP. Even if it's not right for you, your friends talk to you.
Right.
And you don't know if their primary care doctor, one, if they have one, but two, if their primary care doctor has talked to them about it. Maybe not. Odds are, actually, probably, they haven't.
Right.
And it's a great opportunity to just bring it up. you know, even if you're not enrolling in the study, I think, you know.
Just normalizing sexual, like talks about your sexual behaviors and things like
Right.
that. Right.
Right.
Yeah, it's important.
It is.
We talk about it all day, every day, right? We talk about sex all day,
Right.
all day. So it's really easy for us, but
Right.
for everyone else, there's still a lot of stigma.
Yes.
We understand that, but well, we're trying to break down those walls and we're trying to move on to the future.
That's right.
All right. Good answer. All right. So what? Now you guys have a community advisory board. What is their role? What is their role in with your vaccine trials? What do they do? Who wants to take it on that?
That's it.
Ian.
So we do have a community advisory board. It's a very representative group, and we inform them about the work that we're doing. We talk about the studies. We get feedback from them about how to identify people who may be interested, how to communicate the goals of the study to the larger community, help us develop an educational program like this that can help reach out to folks. You know, we do have people on our staff that are members of the community, but we want to. It's not one community, so we need to figure out how to reach as many different folk within, you know, the communities that could potentially benefit from the work that we do.
Hey everyone, thanks for watching. Make sure to give a thumbs up, and if you like what you see, subscribe for more content.